надо микрофон к-нему, да, какой-то?
Можно вот как мы веб-камеру купили, и все, там микрофон встроен, причем здесь очень хороший микрофон.
А если нет веб-камеры? Можно получится?
Нет, можно микрофоны, но они будут по стоимости хорошие микрофоны.
Я просто на работе у нас веб-камеры нету, и стационарные такие компьютеры, но...
Ну, честно говоря, микрофоны будут стоить столько же, сколько и веб-камеры.
Микрофон у нас есть.
Ну, можно тогда его использовать.
Good day, my dear friends. I see any students present. Some students present. Sorry. And we continue cycle of lectures about tuberculosis. Today's topic, complications of tuberculosis. Sorry. Complications of tuberculosis. All complications of tuberculosis we can divide it on two groups, specific and non-specific. Specific complications are complications which can form in tuberculosis only, which characteristic for TB only. For example, tuberculosis pleurisy, tuberculosis caseous pneumonia, tuberculosis meningoencephalitis, etc. That's why cause of these complications is Mycobacteria of tuberculosis. Non-specific complications. This is complications which can form in different diseases. They can happen not only in tuberculosis, but also for other non-specific pulmonary diseases. For example, hemoptysis and pulmonary hemorrhages, spontaneous pneumothorax, pulmonary heart disease, atelectasis, amyloidosis, etc. These complications can develop in different diseases. For example, in oncology diseases, if lung tissue is destroyed, in bronchiectasis, for example, etc. Today we will discuss about two complications of tuberculosis. This is hemoptysis and spontaneous pneumothorax. First of all, hemoptysis and pulmonary hemorrhage. Hemoptysis, about 100 milliliters of blood simultaneously or during the day. Bleeding, its classification of hemoptysis, bleeding from 100 to 500 milliliters of blood during one day, and profuse bleeding, evacuation of blood more than 500 milliliters, same time or during the day. Hemoptysis occurs during coughing when granulation tissue covering the cavity of destruction or tumor is injured. Pulmonary hemorrhage occurs because of break of pulmonary vessels, sclerosis of the lung tissue, or bronchial arteries. Diagnosis of hemoptysis and pulmonary hemorrhages. We should differentiate true pulmonary bleeding with other hemorrhages from oral cavity. First, bleeding from the oral cavity. Possible in trauma of the mucosa of gums or oral cavity. On this photo, you can see bleeding after tooth extraction. Next, bleeding from nasopharynx. Increased blood pressure and blood flows down the posterior wall of the pharynx. On this photo, you can see laryngoscopy, inspection of the posterior wall of the pharynx. Next, bleeding from esophageal varicose veins. Typical dark blood without coughing. Expectoration of dark blood without coughing. And this variant of bleeding appear in liver cirrhosis. That's why should be symptoms of liver cirrhosis. On photo on the left photo, you can see esophagoscopy and varicose veins of the esophagus. And on the right photo, you can see a head of jellyfish. Symptom of liver cirrhosis. Next, differentiation. Gastric bleeding. What symptoms are correctly for this bleeding? First, judging. Second, vomit type of coffee grounds. And ulcer in anamnesis. On the left photo, you can see gastroscopy with peptic ulcer bleeding. Peptic ulcer with bleeding. And right photo, coffee grounds. You can see. Next differentiation, heart bleeding. It's possible at mitral heart defects. Pressure in the small circle of circulation is increased and red blood cells migrate into the alveoli. Macrophages and erythrocytes are determined in the sputum in this pathology. On the left photo, you can see mitral valve insufficiency, mitral heart, and the right side, macrophages and erythrocytes. What about the true pulmonary hemorrhages? Sputum stained with blood, with a frothy consistency, stands out during coughing. That's why expectoration of blood connected with coughing always. And alveolary epithelium is determined in the sputum. In true pulmonary hemorrhages. Pulmonary hemorrhage causes stress and death, anxiety in the patients. Pulmonary hemorrhage causes stress and fear from the doctor and medical staff. Only adequate medical care is the key to effective treatment. The steps of providing specialized care in pulmonary hemorrhage. Upon arrival to the hospital, patient is taken to the ward on functional bed. We have to put a basin for visual estimation of blood loss volume. Next step. Two systems with physiological solutions are charged for intravenous injections. We need a set of tools for intubation and vacuum suction in order to prevent asphyxia with profuse pulmonary hemorrhage in the hospital. On this photo, you can see the trachea and bronchi are obturated by blood clots. It's very, very dangerous for patients. First drop counter is connected with cubital vein and forearm. The second one at the veins of the lower limb. Before connecting, we should take the patient's blood to determine group and rhesus factor. Next step, mobile X-ray device produces X-ray for the diagnosis and localization of the disease. We should find cause of bleeding. Next step, drug therapy. First group of drugs we used which affect on the coagulation system. That's why coagulation therapy we use. Disenon, etamzilat, tranexam, aminocapronic acid, etc. Next, coagulation factors we should use. For example, fresh frozen plasma, cryoprecipitate, platelet mass, next group of drugs. This is drugs that reduce the pressure in the pulmonary small blood circulation. For example, nitroglycerin, perlinganate, socket. They are administered intravenously under blood pressure control. Next group of drugs, procoagulants. For example, Minadiol, Vicasol, will work after 1 day, these drugs. It's not emergency. Next group, drugs distribute blood in the abdominal vessels. For example, atropine and its derivatives. Next group of drugs, drugs that increase blood viscosity. For example, gelatinol. Next group, drugs straighten the vascular wall. For example, ascorbic acid at a dose of 10 milliliters intravenously. Next method of treatment, pneumoperitoneum, is imposed in case of failure of medical therapy. It means the injection of air into the abdominal cavity. We used therapeutic pneumoperitoneum. This is the introduction of air into the abdominal cavity for therapeutic purposes. As a rule, the puncture is made at a point located 3-4 cm to the left and downward from the navel. The needle is attached to a pneumothorax apparatus. The amount of injected gas ranges from 500 to 600 cubic centimeters. After the gas injection is complete, the needle is removed. A sterile sticker is applied to the puncture site. On this photo, left photo, you can see X-ray diagnostic after the pneumoperitoneum. And we can see the air under the dome of the diaphragm. Gas compress the lung tissue and stop bleeding. Also, we can use artificial pneumothorax. This is introduction of air into the chest, and into the pleural cavity. On the left photo, you can see partially collapsed lung. On periphery, we can see compression of lung tissue, and on periphery, lung pattern is absent. This is sign of pneumothorax. If there is no effect of therapy, we perform bronchoscopy with tamponade. On the left photo, you can see bronchoscopy and bleeding bronchus from bronchus. On the right photo, you can see occlusion main bronchus. Scheme of occlusion. Mechanical plugging of bronchus stops pulmonary hemorrhage, but the tampon is setting not more than 3 days. This period allows to prepare a patient for surgery operation. On photo, you can see thoracotomy and the lung tissue. Next step of providing specialized care in pulmonary hemorrhage. If conservative treatment and tamponade is not effective, we can do operation. That's why possible resection of part of the lung is the best option of radical surgery if patient has the local process. We can use wedge resection of the lung, lobectomy, or pneumonectomy. Volume of operation depends on volume of process in the lung. The elimination cavity with ligation of the bleeding vessel is performed in case of bleeding from the cavity of destruction, when lung resection is impossible. For example, when affected both lungs. Next complication of tuberculosis is spontaneous pneumothorax. This is non-specific complication also because can form different diseases. Lung tissue is elastic. Because of it constantly makes breathing movements. Lung tissue tends to collapse due to its flexibility directed to the root of the lung. On this photo you can see components of lung tissue. This is bronchi, arteries, veins, etc. The lung tissue is not muscle fiber, so breathing movements are performed by intercostal muscles and the diaphragm. Respiratory movements occur due to the suction effect of pleural cavity and negative pressure in the chest from minus 12 to minus 14 centimeters of water column. We used water manometer. And during increasing of the volume of pleural cavity, lungs are stretched and inhalation comes. During reducing of the volume of pleural cavity, the lung is collapsing. exhalation occurs. Physiologically, lung is in expanded state, but when air is getting to the pleural cavity, it partially or completely collapses, turns off from gas exchange. On this picture, you can see collapsed lung, around of lung tissue, gas. This gas compressed lung. The problem of the treatment of this condition is in timely evacuation air from the pleural cavity and creating conditions for the closing of the perforation. Classification of pneumothoraxes. First pneumothorax named traumatic, external and internal. It's possible as a result of penetrative wounds of the chest cavity or the trauma of the chest with broken ribs. For example, on the left photo, you can see gunshot wounds. On the right photo, you can see traffic accident, injuries of the thorax. This is traumatic pneumothorax. Can form as a result of affection of parietal pleura first of all. Visceral pleura can affect it also, but first of all affected parietal pleura. Next, pneumothorax name pathological or spontaneous. There are three variants of spontaneous pneumothorax: open, closed, and valvular. And more detail about these pneumothoraxes. What are the main reasons of spontaneous pneumothorax? First of all, bullous emphysema of lungs. Bulls can rupture and can form pneumothorax. Gas can enter into pleural cavity. Second reason, ruptured cyst. In this case, air goes into the pleural cavity as a result of rupture of cyst. On the left photo, you can see bulls on visceral pleura, and on the right photo, you can see lung cysts. They can rupture also, and gas can enter into pleural cavity. That's why spontaneous pneumothorax can appear as result, can form as a result of rupture of visceral pleura. It must be affection of visceral pleura. What clinical picture of pneumothorax? Clinical symptoms occur during physical stress, but often in complete rest, even during sleep. It's characterized by a sharp pain in the chest, cough, shortness of breath. The air, more detail about of each type of pneumothorax is first opened pneumothorax. The air circulates between the bronchial tree and pleural cavity through the perforations. The lung is partially or completely collapsed. On this CT scan and X-ray, you can see affection of the lung of the right side, and we can see collapsed lung. Lung is compressed, and around we can see gas. The main X-ray symptom of pneumothorax is absence of lung pattern. Lung pattern is absent around compressed lung. We can see gas. The air is in pleural. Next type of pneumothorax is closed. The air is in pleural cavity in a small amount, and the defect of visceral pleura is closed. Defect of visceral pleura can close as a result of fibrinosis. The lung is collapsed, and on X-ray and on CT scan we can see lung compression and small quantity of gas around of lung. And we can see absence of lung pattern around lung pattern on periphery. Next type of spontaneous pneumothorax, valvular or intense. Air during inspiration enters the pleural cavity, but during exhalation, the effect of visceral pleura is closed. It's formed petal valve, and gas not exit from pleural cavity. The volume of pleural cavity with each breathing increases, but volume of lung decreases. Increased pressure in the pleural cavity leads to total lung mediastinal shift. The clumping of the upper and the lower vena cava. Insufficient intake blood in the right heart and heart failure. And on this X-ray you can see X-ray on inhalation, you can see shift mediastinum to the healthy side, and vena cava is clumped. In the right side, lung pattern is absent. Lung absent. The clinic is characterized by sharp pain chest, increasing shortness of breath, cyanosis, and edema of the face, neck, upper extremities, superior vena cava syndrome. And on this photo you can see a face of patient before and after treatment. If the lung is fixed to the parietal pleura by commissures, Air enters through the intercostal space to the soft tissue of chest, face, abdomen, etc. Subcutaneous emphysema develops. On this photo, on the left photo, you can see face of patient with intense spontaneous pneumothorax. And on the right photo, you can see rentgenogram with subcutaneous emphysema and with spontaneous pneumothorax on the left side. On the left side, lung pattern is absent as a result of compression of lung. And spontaneous pneumothorax can be a total or local. On this photo, on this rentgenogram, you can see in lower part of the chest of right side, you can see local compression of the right lung. This is limited spontaneous pneumothorax of the costal localization. This is result of adhesion of pleura after tuberculous pleurisy. On this rentgenography, you can see pneumothorax at disseminated tuberculosis. In the left side, we can see absence of lung pattern on peripheria, compressed lung tissue, and disseminated process in both lungs. In the right side, we can see cavity of destruction and dissemination also. On this rentgenography, we can see bilateral pneumothorax and adhesion of pleura after pleurisy. On CT scan, on this CT scan, we can see detachment of the right lung and subcutaneous emphysema. And you can see right lung is compressed, and on periphery we can see dark color. This is gas inside of pleural cavity, which compressed lung tissue. On this photo, you can see a layer of CT scan, one layer only, and we can see collapsed right lung. Around of the lung, gas, dark color, and in lower part of the chest, we can see the liquid level. This is hydropneumothorax. Gas compress fluid, therefore we can see horizontal level of fluid. And in the left lung, we can see bullous emphysema, one bull, localized subpleural. Treatment of spontaneous pneumothorax. First of all, the patient must be delivered at wheelchair to the X-ray room and do overview of chest of exhalation. on exhalation. If pneumothorax is limited by commissures, it's necessary to carry out X-rays and mark the place of detachment of the lung. After diagnosis, the patient is transferred to the dressing room for further manipulation. And you can see here instrument for puncture. Pleural puncture with removal of air is held in a place of easy detachment. It's enough from 2 to 3 punctures for the full straightening of the lung. On this photo, you can see doctor do puncture of pleural cavity for patient. Under local anesthesia, a trocar is held thoracentesis and trocar is inserted through the tube exercise from the dropper, which is connected to aspiration system. Similar events are held and tension pneumothorax, but if the patient has bradycardia, then puncture of pleural cavity should be carried out immediately after diagnosis of the affected site in X-ray room without anesthesia. We should do decompression of the pleural cavity. Usually, puncture do in 5th or 6th intercostal space on media axillaris linea media axillaris, on upper border of the rib, or puncture do in 2nd intercostal space on linea media clavicularis. Surgical treatment of spontaneous pneumothorax. This is next step of treatment. After inefficient drainage, patient have to go to CT scan for the detection causes of spontaneous pneumothorax. On this photo, you can see bullous emphysema of lung, many bulls in the left lung. This is more often causes of spontaneous pneumothorax. If bulls have limited distribution, we use thoracoscopic electrocoagulation. It's enough for treatment. And on these photos, you can see balls of the lung. In the left side CT scan, you can see affected both lungs, but left lung is more affected. More balls in the left lung. And on the right photo, you can see balls of pleura in thoracoscopy, video thoracoscopy. If balls have common character or giant size, thoracotomy is performed with suturing or welding ball. On this photo, you can see giant bulla of the lung contain gas and can rupture. It can be source of spontaneous pneumothorax. In these cases, do thoracoscopic operation. That's why we finished today's topic. And if you haven't questions, we students, you listen me? Do you listen me? Next time we continue course of our lectures next Wednesday. If you haven't any questions, write please, have your questions. Good luck. See you next time. Goodbye.